the research you have done around chronic pain, I think, is game-changing. I think it's helping so many practitioners, it's helping so many patients all over the world find healing where previously there was stress and heartache. So right at the top, what is chronic pain? What do those two words mean?
Yeah.
And how common is it?
Yeah. Well, everyone's experienced pain, and we need pain. Pain is a protector. Pain is something that, it turns out, our brain creates and generates. So what I say to all of my patients, pain is a discomfortable experience, basically. But it's also an emotion. And so when you get down to it, we kind of think is every time someone has pain that there must be something wrong with their body. And it turns out, as we'll discuss, the vast majority of people who have chronic pain actually don't have a structural problem in their body. Most people with acute pain probably do, because if you break an ankle or something. And if you break an ankle, you want pain because it tells you, it's a message that your brain is giving you to stop. Don't walk on a broken ankle.
Mm.
But it turns out if you have a broken heart, you might get chest pain, but it might be due to your brain giving you the message that there's something amiss, there's something wrong in your life. And so what I say to all my patients is you can't understand pain unless you understand how the brain works. So we start with that because it's a much broader view of understanding pain that that we can get into.
Yeah. When you say acute pain versus chronic pain, what does that mean? And do you have some examples of common conditions or syndromes or diagnoses that fit under this chronic pain diagnosis?
Yeah, for sure. Take headaches. In the U.S., 25 million people suffer with chronic headaches. And so if you have headaches, you think there must be something wrong. There is something wrong. You have pain. But it's chronic. It's not like you hit your head and you have an injury to your forehead and it hurts and it's going to go away in a couple of days, or you have a tumor or an infection or a bleed. As physicians, we know there's certain structural problems that cause headaches. But the vast majority, 95, 98% of people with chronic headaches don't have a structural disorder. They go to the doctor, they get their CAT scan or MRI, they get tested for their sinuses, their teeth, their ears, their mouth, etc., and there's nothing wrong. So what's the cause? It's chronic headache pain, what we call primary headache, right? So what's the cause of that? Most doctors say, well, it's genetic, or I don't know, or whatever. And what we're saying is we know exactly why people have chronic headaches, because we can talk to them. We can listen to them, we can hear their story, and we understand how the brain works and how the brain can create a cycle of pain due to neural circuits that get activated due to stress and emotions and life situations. And then it continues to get activated by this vicious cycle of pain leading to fear of pain, which leads to more pain.
I reflect back on my career to date. And I remember early on, as a primary care doctor, some of the most frustrating cases were those patients who would come in with chronic pain, whether it be chronic migraines, headaches, bilateral arm pain, whatever it might have been. Because as a medical doctor, certainly back then as a very junior medical doctor, I didn't really feel I had the tools to help these people. As I say that, Howard, I remember distinctly one afternoon I was in Timperley. I was in a practice in Timperley. I can remember this lady coming in, maybe 60, 62. She would smoke 15 or 20 cigarettes a day. She was really struggling with life. She was on a whole host of painkillers. I had all these letters from the pain clinic that, just increase the pregabalin by 25 milligrams. I remember seeing her thinking, everything we're doing, nothing's working. And all I've got is a specialist letter telling me to increase the dose of a pain medication by 25 milligrams, even though nothing's working anyway. And I wish I could go back to that patient now, knowing what I know through your research, through my own clinical experience. I wish I could go back and help that lady, because I think she's an example of, A, that patient is struggling and suffering, okay? But I also think doctors, I think they feel really powerless and frustrated with cases like that. And I think what ends up happening, in my experience, is that the patient often feels that they haven't been heard. This guy, this woman, whoever it be, this healthcare professional is not taking me seriously.
We are spending billions and trillions of dollars for Band-Aids. We're talking about Band-Aid care. Put something over it, as opposed to look and find the underlying cause. And the pain that is experienced in chronic headache and migraine and irritable bowel syndrome and fibromyalgia and chronic pelvic pain, and we've done research in looking at the causes of these, and most people with neck and back pain, we'll talk more about that in a minute. The pain they experience is real. It's not imaginary. It's not in their head. But it is in their brain because of neural circuits in their brain when the doctors can't find anything wrong, which is the case most of the time, as you've experienced. So the doctors are frustrated. They can't find anything that's wrong. They can say, oh, have this surgery or do this to fix it. That's not going to happen. But they can get better. And that's the work that we've been doing, and a lot of other people are doing as well. But it starts with understanding the person. It's listening to them and understanding them and getting to know them and understanding what's going on in their life, so they can see what are the things which led to this situation, and they can know that you're not invalidating them, you're not stigmatizing them, you're not blaming them, that the pain is real, and that they can get better. What a hopeful message, as opposed to the incurable message that are mainly given by so many doctors and groups that are working in that space.
This idea that when we experience pain, most of the time there's nothing actually structurally going on in our body, I think is quite profound for people, because I think we grow up with the understanding that if we have pain, there's a physical cause of that pain. And you mentioned earlier on that the brain creates this experience of pain. You mentioned something that I think many people have experienced. When they have a broken heart, they can literally feel a pain in their heart, right? But nothing physical has actually happened. So help us understand that. What's going on? How does the brain generate this experience of pain, and why does it do it as well?
Yeah, it is amazing. The book that I recommend to people is How Emotions Matter by Lisa Barrett, neuroscientist in the States. And there's some very famous British neuroscientists, Friston and Clark particularly, have written about this extensively. Their work is a little harder to read. It's very deep. But this is emerging neuroscience of how the brain works. Well, how does the brain work? Our brain creates what we experience. How do we see? We don't see with our eyes. We don't. Light comes in our eyes, but the light impulses have to be transformed electrically through the visual cortex to create the images that we see. And so our brain creates what we see, and part of it occurs in what we expect to see. The other day, I was driving by my friend's house. I hadn't seen him in a while. He was on vacation. I drove by. He's standing in his doorway. It's like, oh, wow, he's home. Awesome. I drive up to the drive, knock on the door. There's no one home. My brain created the image of him standing there, basically a hallucination. And police officers, this is controversial. My wife doesn't like me to talk about it, but they go to the scenes of crazy stuff, especially in the States. And they have to say, do I see a gun or not? Well, sometimes they see a gun that's not actually there, or vice versa. If I gave you prism glasses that turn the world upside down, you'd see everything upside down, but only for a few days. And then your brain would switch the images to be right side up again, because our brain creates what we see. Our brain creates what we hear. The other day I was at a meeting, a young woman got up and said, "Good morning, America," which is like, that's a weird thing to say. She actually said, "Good morning, I'm Erica," but I didn't know her name. But our brain, my brain was just latching onto something and creating something. And so when you break an ankle, it's not your ankle causing pain. An ankle can't cause pain. When you touch a hot stove, it's not your finger. The impulses go to the brain, but the brain decides, and this is the craziest thing, but it's true neuroscientifically, the brain decides whether to actually turn on pain or not, whether to give you the experience of pain or not. How do we know that? Because a lot of people have experienced themselves, you get an injury and you have no pain at all. So the brain decides whether to turn on pain or not, and it's there to protect you. It's something that everyone needs. It's like a smoke alarm. And, well, the research shows, neuroscience research shows that emotions and stress activate the exact same parts of the brain as does a physical injury. And we can talk about why our brain might do that. We don't know for sure, but whether God created us that way or we evolved that way, but that's how our brain works. So the pain that occurs due to a fracture is exactly the same as the pain that occurs due to a stressful situation that occurs in our life. It's real pain, and it can be severe pain. And that's what people say. How can the pain be so frigging severe and not be due to a structural injury? It's amazing, but it's true. We see it every day.
Yeah, and that's, I think, the power of a lot of your work, a lot of your research is helping to give scientific validity to something that many practitioners have experienced, many patients have experienced, that emotional pain, emotional injury can totally manifest as physical pain. I have found, like you, Howard, I think that many cases, arguably the majority of cases with chronic pain, can be healed. In my experience, at least, I'd love your view on that, without using any medication, if you take time to help the patient understand what's going on, get to the root cause. I mean, what would you say to that?
Exactly. It's 100% true. And we have data now showing that. I can talk about that in a second. But the most important thing is that it's not all in your head. When a doctor says, or anybody says it's all in your head, it's cruel.
Yeah.
And it's ignorant, because it implies that it's their fault, that they want the pain somehow, that they're crazy or mentally deficient, or making it up. And none of that is true at all. And so that validation is so important.
I guess, you can look at it this way. If someone had a physical injury, like we could see, let's say, their ankle, and it was red, it was hot, it was swollen, and they were hobbling for a few weeks and had to, take crutches to work with them. People would be sympathetic. They could see that. They could understand, and you need some help. I get it. You're in pain, right? We have an understanding of that. But a lot of emotional pain is hidden. We can't see it. The people around you can't see it. So therefore, one of them we have sympathy for as a society. The other one, we kind of ignore.
Right, and we're not really looking at the whole person. So if you take, for an example, kind of a common story, right? You take a young woman, say, whose father was critical, yelling and screaming sometime, maybe alcoholic, kind of that sort of thing. And she grows up with this sense that life isn't safe, that people are unpredictable. People in my life are unpredictable around me and can yell or scream at me, or even worse. And then she grows up, and then when she's 15, she has a boyfriend, and then he betrays her, or cheats on her, or sends pictures of her around the school or something like that. And then she gets migraine headaches. Do you have sympathy for her? Of course you do. And then she's in her 20s, and she marries a guy who happens to be kind of like her father, kind of maybe abusive or maybe harsh with the children. And then she starts getting irritable bowel syndrome or pelvic pain. Do we have sympathy for her? And then when she's 35, she divorces the jerk, but still not paying child support or whatever. And then she gets in a small car accident. And then her neck starts to hurt, and it gets worse. And then her whole back starts to hurt. And then she starts to feel anxious or depressed. And then maybe she gets pain all over, and they say she's got fibromyalgia. And now at the end of this, she feels completely broken. And people maybe are looking at her like, just get on with your life. What's wrong with you? Nothing. Do we have sympathy for that person? Are you kidding me? Her whole life has been one which cries out for understanding and cries out for her to be heard, listened to, respected, cared for. And when you look at it that way, yeah, this pain is real, and all these pains are due to the stress that's been caused in her life, none of which is her fault.
When you use the term chronic pain, are you able to list some of those conditions that fall under that umbrella term? And I've got a reason for asking this. You've mentioned headaches already, but if you could just sort of go down a common list, because I think this conversation and what we're talking about is relevant to almost everyone, whether in their own lives or someone very close to them. And I wonder if you might just make it super, super clear for us who we're referring to.
Yeah, exactly. Well, chronic pain just means any pain that's lasted for, they say 3 months or 6 months as the definition. But the conditions that are commonly what I would call neural circuit-based pain, in other words, brain-generated pain in the absence of structural problem, are primary headaches like tension and migraine headaches, and other headache conditions like occipital neuralgia, trigeminal neuralgia. Most people with TMJ problems do not actually, you can find that there's problems on the x-ray, but actually when you talk to them and take their history and take time, and we can talk about how we do that, how we assess people to know for sure TMJ pain most of the time is neural circuit based or mind-body type pain. If you take people with costochondritis, chronic chest pain, again, in the absence of heart disease or lung disease, most people with, the vast majority of people with irritable bowel syndrome and what's called non-ulcerative dyspepsia is the word I'm looking for. If you take people with chronic pelvic pain, they may be diagnosed as having pudendal neuralgia or pelvic floor dysfunction or vulvodynia. But all those things are just names. They're just describing that you have chronic pain.
Fibromyalgia?
Fibromyalgia, absolutely. And we did a study on chronic neck and back pain, and we haven't published it yet. But a colleague I have in the States examined 220 consecutive patients coming into his clinic with chronic neck and back pain. He's a physiatrist, physical medicine physician. And he determined that 88% of them had non-structural pain. I mean, that is shocking. Because if you go to a doctor with chronic neck or back pain, or a chiropractor, or a massage therapist, or a physical therapist, they're going to say, oh, well, you have degenerative disc disease. Look, it's on the x-ray or the MRI. You have got bulging discs. But everyone has those. And if you look closely at the data, and we can share this data with you and your listeners, the vast majority of people have those things on x-ray, as I do in my neck, without pain at all. And so we have to be very clear and very careful what we're talking about. And everyone needs a very careful evaluation. But those are the main conditions. But the brain can produce anxiety and depression when we're under stress, obviously. The brain can produce fatigue that can be severe and overwhelming. And we see that all the time. The brain can produce eating disorders. The brain can produce, well, we can talk about long COVID as well, of course. So there's just so much. The fact is that the reason that my patients and your patients have these conditions is because they're human. They're just human. They have a brain, they have a body, they react to stress that occurs in life, and everybody has some of these. Everyone does. You know, I like to say when I started my internship, I was a young doctor. I got diarrhea for 6 months. Well, was that diarrhea real? Well, it's real. You can see it. But it wasn't because I had something wrong in my bowel, if I can say this on here. I was scared shitless, of being a young doctor and making mistakes and hurting people. And I was just being human.
You know what's interesting about all those conditions that you've just listed is that almost without fail, I would say those are the conditions that we manage in medicine pretty poorly. I don't think that's controversial to say. I think patients know it. We as medical doctors know it. Those are the conditions where it's often, as I've already mentioned, quite frustrating because actually the tools with which we're trained, the tools that we learn at medical school just don't work that well. And this is, I guess, one of my biggest realizations as a doctor throughout my career has been how important the mind is in our lives, our physical health, our vitality, how much a role it plays. But we are literally taught zero about that at medical school. Now, that could also be because research was limited at the time when I was at med school, but I don't see much evidence of that changing at the moment. When I've spoken to a mutual friend of ours, Gabor Mate, in the past, and Gabor talks a lot about trauma and how still in many medical schools, the trauma word doesn't even come up at all in the entirety of medical education. And now that we know how much early life trauma affects our risk of autoimmune disease and all kinds of other conditions later on in life, it's baffling as to why it's taking this long for it to get into medical school training, because doctors are getting frustrated, patients are feeling underserved. But that thing you just mentioned, Howard, about MRI scans, I think that's a really great point to dive into. I wonder if you could share some of those statistics if you happen to hand.
If you take 30-year-olds, people in their 30s, and you do an MRI, these are people with no pain at all. 40% of them have degenerative disc disease. 30% have bulging discs. These are 30-year-olds. These are normal findings that occur with aging. So what happens when you're 50? 50-year-olds, 80% of people have degenerative disc disease with no pain. 60% have bulging discs with no pain. 30% have herniated discs with no pain.
So here's the problem that I've seen as a medical professional, right? The patients there, they've either seen a specialist or got a scan. As the primary care doctor, you get the scan results and it will say bulging disc at L4 or L5. Right? No nerve impingement or something. There'll be some kind of report. And then you'll say, or as a professional will often say, oh, the reason you have your pain is because of that disc problem on your scan. And that's a very dangerous thing to say to that patient, I think. What would you say to that?
Incredibly dangerous and maddening.
Because, why maddening?
Well, because it not only gives them the erroneous diagnosis, and also I want to talk to you more later about how we assess to make sure that we know that the bulging disc isn't the cause of pain. But it's giving them an erroneous diagnosis, so it's making them think that there's a problem that can't be fixed or needs fixing with medication or injections or even surgery. And we see so much, maybe not quite as much here as in the States, but so many surgeries that are being done on people's necks and backs for treating the MRI, not treating the patient. And there's never been a randomized controlled trial showing that surgery for neck or back pain, axial pain, is better than watching it or exercise or physical therapy or anything. There's no evidence that this is what we should be doing, but we're spending billions of dollars, trillions of dollars, billions. But it's not that so much, it's that it also makes people worse. Because what happens is in the brain, we'll talk more about this, what happens in the brain is that the more you're fearful of every time, if you have back pain, the more fearful you are of it, it's going to get worse over time. Because the neural circuits in the brain, you're getting a positive feedback loop. Whereas pain leading to fear, focus on it, worry about it, frustration with it, it actually makes it worse because that's how those neural circuits work. So it's really, and it's all out of, I don't know how to say this nicely, but not understanding the brain and not understanding the data, the scientific data we have about these MRIs, because these abnormalities go up to 90% when you're 60 and beyond. But these are people without any pain. It's like saying you've got wrinkles on your skin, and that's the cause of your headaches because you have wrinkles, or that your hair is getting gray, and that's the cause of your migraines. You know, that's the kind of thing that we're doing.
And I think this is a key point, Howard, for me, how we as healthcare professionals can unwittingly make the problem worse. Because as you say, this can worsen things. This can create a fear. And it also, what we say as healthcare professionals, certainly as doctors, has real power. It can really positively or negatively influence what that patient believes, what they feel. Like, let's say they're one of these many people who have abnormal MRI scans of their spine. They've got a bulging disc, let's say. They probably had that for years, well before they actually had the pain. Maybe that bulging disc has nothing to do with their pain at all. And then here's the problem, the way I see it, is that if we say that to the patient, we found the cause of your pain, that patient then goes out into the world with the belief, my spine, my disc is causing my pain. So everything they do after that is based on an erroneous belief system. Whether they're trying treatments or therapy or anything, it's all based on that truth. And that truth actually may not be true. Now, Howard, what if I might share with you my own journey with, through, and now beyond chronic pain? Because I think perhaps if you hear that, you might be able to explain various bits along the way. Would that be okay?
Yeah, that would be great. Yeah.
So I'm now in my early 40s. Okay, so...
Really? You look much older. I'm sorry. I was going to say younger, but then somehow...
It's good. You
just to make a joke, yeah.
When I was... again, because I really feel it's a thing of the past for me, that it's hard now to remember step by step what happened, but let me share with you some of the key things. So I've always been pretty fit and active. And I think it was in the final year of medical school that I was helping my flatmate at the time move into a new flat that we were all going to move into. And all afternoon I was lifting heavy boxes out of a car, probably with appalling lifting technique because I knew nothing about it at the time. I never had a problem with my back or anything, so I wasn't thinking. And at one point during the afternoon, I remember getting something out of the back. I had a sharp pain in my lower right back. I dropped everything and I just went onto the floor. That's the first time, to my recollection now at least, that I experienced back pain. Now, that led to maybe a 10-year history where the quality of my life was hugely affected. I started off against the doctor, the university doctor. I went to...
But what happened immediately? So you fell down, you had this acute pain, right?
Yeah.
And then did you get up and finish the work, or did you have to stop for the day? And what happened in the next 2 or 3 days, if you recall?
Honestly, I cannot remember with any degree of accuracy. I probably would have stopped. I may have sat down for a while. I may have rested. Maybe I helped get the remainder of the boxes up. I don't really know. But all I remember now, at least, is that I went on a journey for several years where I would take painkillers. I would go and see a physio. I remember I got referred to a physio. I think I paid privately for loads of physio sessions, limited use. Again, I'm not here to have a go at physiotherapy. I'm just saying for me, it was, I was doing some strengthening exercises.
But was the pain coming and going? Was it turning on? Was it turning off? Was it there constantly?
I don't think it was there all the time.
Yeah.
I think I would just have an awareness of it. If I sat down for too long, I think I'd feel it. At some point in that journey, I think I don't know when that was. It was probably, I don't know, something like 1999, 2000, something like that. I moved back to the northwest of England from Edinburgh in 2003 to help look after my dad. And I was having real problems. Like I was a junior doctor at the time. I was really struggling sometimes with the long ward rounds, and my back was really bothering me. I had to take time off. And I think I once went to my GP and they referred me for an MRI scan. Or I actually think it was at the hospital I worked. I got an MRI scan there. And this is the first time, and I give the spinal surgeon who had the consultation with me a huge amount of credit for this. This would have been back around 2003, 2004. There was a disc abnormality on my MRI scan, and I would